Be me. Let's see. Or should I like turn it? Yeah. Okay. All right. Well, let's get started. We have a full schedule today, so I'm really excited. Welcome and good morning. Thank you for coming to our 25 years of discovery, Rein and Sarcoma Research Symposium with the University of Minnesota. We are so excited to have you join us today, both in person, those of you who are here, and we've got a great group online who is also attending virtually. This is our 25th anniversary milestone at Rein and Sarcoma. And my name is Lachelle Semenko. I'm the executive director here with Rein and Sarcoma. It's an honor to share this space with such dedicated and passionate professionals who are working toward a better understanding of sarcoma treatment. First, I'd like to take a moment to extend a very special thank you to Dr. David Largaspada and the University of Minnesota for generously hosting this event today. We're grateful to them for creating this opportunity for us to come together and share the spirit of collaboration and discovery. So today's program is packed with remarkable presentations from researchers across the country, all of which have received research funding from Rein and Sarcoma and or are engaged with our Rein and Sarcoma Scholar Program. So we'll dive into cutting edge research and innovative approaches to sarcoma treatment. I feel very fortunate to know these incredible people. They give me hope, knowing that every day they are working on improving treatments and possibly even a cure for sarcoma. So before we begin, I'd like to introduce Dr. David Largaspada, the Deputy Director Interim of the Masonic Cancer Center and Professor in the Department of Genetics, Cell Biology, and Development. He's also a current board member and the chair of the research committee here at Rein and Sarcoma. Dr. Largaspada will officially kick us off for today's event and set the stage for the day ahead. So, Dr. Largaspada, the floor is yours.
I have those comments. All right. Well, thanks so much, Lachelle, and thank you all for being here today. Our guests include sarcoma patients, survivors, medical professionals, and supporters of Rein and Sarcoma, and I feel very privileged to participate in this event today. As a past recipient of funds from Rein and Sarcoma, but also just recognizing the great relationship that we've had with Rein and Sarcoma over the years here at the University of Minnesota and the Masonic Cancer Center. So we have a full agenda ahead of us, and I'm delighted to be introducing our esteemed speakers who are leading the way in sarcoma research and treatment. So without further delay, let's jump into our first presentation. Our first presenter is Dr. Jaime Modiano, the Perlman Professor of Oncology and Comparative Medicine and Director of the Animal Cancer Care and Research Program at the University of Minnesota. He will share his insights on cancer prevention by attacking the aged, cancer-permissive environment. So please welcome Jaime.
Thank you, David. And thanks everyone for coming, and thank you, Lachelle and RIS for the invitation. So do I need to start my thing here or?
You, and then here we go.
Great, thank you. I was reflecting on the fact that we have been working with Rein and Sarcoma for 18 of their 25 years. So it's a true honor and passion to be with you. And I don't have enough words to express the gratitude that we have for all your support. And hopefully what I'll give you today is a little bit of hope for those maybe who are patients now and those who hope never to be patients in the future. So I have some disclosures that I need to go through real quick, so you can read them. None of them are particularly relevant for this presentation. Some learning objectives that I'd like to put forward is that I want, for many of you, the idea of youthful fitness preventing cancer might be new. So I want to help you understand what we mean by youthful fitness and what we call the cancer permissive environment. I want to tell you about the work that we've done to actually characterize what we call the cancer permissive systemic environment. And then hopefully appreciate how attacking this environment can actually provide opportunities for cancer prevention. And if you remember nothing out of the presentation, I'd like you to remember these two things. One is that secondary cancer prevention. So primary cancer prevention basically addresses changing behaviors. Secondary cancer prevention is using medical interception, so trying to actually change something that will prevent cancer. So interception is feasible and might be an effective method to reduce the cancer burden. So our proof of concept that I'll talk about today is something we've done in companion dogs. And so there are a lot of questions about how we would apply this in humans, but at least we have some idea that the feasibility is there. And the second thing that I want to tell you is about 20 years ago, I thought, maybe if we could actually help cancer patients survive, we could make the neurologists really busy, right? Because we'll let people get really old and develop other diseases. But as I think about it now, and maybe it has to do with my own perception of what it's like to get old, I do wonder whether sometimes we're doing people any favors by preventing death from one horrible thing just to let them lead a horrible life. And as a trained veterinarian, we really value quality of life. And so I think that when we start thinking about cancer prevention and the consequences, perhaps the unintended consequences of cancer prevention, we really have to keep in mind that we have to address all the other things that happen with aging. So the talk today will be divided into 4 short parts. First, we're going to talk a little bit about the link between aging and cancer risk. Not to diminish the importance of pediatric and adolescent and young adult cancers, we know they happen, but the vast majority of cancers in our population are in the older adult and aged population. I'll talk about defining a systemic cancer risk profile. Tell you a little bit about the composition of the cancer permissive environment and how we're trying to intervene to reduce risk. So starting by the link between cancer and aging, I think it's fair to say that cancer largely is a disease of aging. And so these are SEER data, SEER data basically documenting that there's a very small proportion of cancers that occur in the population under 40, and then you see this logarithmic increase in incidence as the population ages for both men and women. There's something that people really don't tend to think about, and that is that until the late 1800s, the expected lifespan for an average human running around the world was about 35 years. And as a species, we evolved over somewhere on the order of 6 to 8 million years from the last common ancestors. So since the arisal of what we think of the Homo sapiens lineage, to really live for about that length of time. And lifespan, it turns out, is an evolutionarily selected property. So mice have evolved over 40 million years to essentially have a lifespan of about 3 or 4 months, right? And so that's where their systems work optimally. And if we take mice and we bring them into our home and we put them in a cage and we feed them and we protect them from hawks and foxes and coyotes and other things that would eat them, mice can live up to 2 years, and the vast majority of them will die of cancer. But they won't get cancer until after that lifespan. By the same token, bowhead whales, we think, can live up to 200 years. And they actually have 200 years of youthful fitness. So a 200-year-old bowhead whale is about the same as a 30-year-old human. Our perception of time is very ingrained in how we live, but time is really relative, right? So people say that 1 human year is 7 dog years, and you can think of that as an analogy that time passes more slowly for a dog. So they have a full lifespan that they live in 10 years than what happens for us in 12 years. So this will become really important because over 200 years, thanks to hygiene and shelter and social protection and medical care, we have doubled human lifespans. And 200 years is not enough for our genomes to adapt to that excess life. So a lot of people hate this analogy, but imagine trying to drive a Ford Escort that works really, really well for 40,000 miles, for 500,000 miles. So after you hit 40,000 miles, something is going to break. And so that's really what we are, is we're designed to work really, really well for 35 to 40 years. And after that, not so much. Now, this lifespan was heavily influenced by perinatal mortality and infant mortality. It's not to say that in the 1600s or 10,000 years ago, there were not probably some 50-year-old or 80-year-old people running around, but they were a small minority. Okay. So the other thing that I think is really important is to recognize that cancer needs a permissive environment to prosper. So we all think about increased cell division becoming a cancer risk, an intrinsic cancer risk, the introduction of mutations being a cancer risk. But this work from primarily from James DeGregory, who actually is visiting us next week, so a plug for people to go to a seminar on Tuesday, really documents how each of these things fit into cancer risk. So what James did in this really cool diagram is he plotted age from 0 until whatever, and then he plotted the relative scale for different properties. And so you can see that in most animals, in most multicellular animals, cell division is highest in early development. So in the egg, in the womb, and shortly after birth. And the rate of cell division decreases quite rapidly. And by puberty, it has reached a very low sort of steady state. When you think about the mutations that we accumulate, there's really very, very strong emerging data showing that mutations accumulate very, very rapidly in this pool of rapidly dividing cells. These are somatic mutations. And as cell division slows down, you also have a relative slowing in the rate of mutation accumulation. You superimpose exposures here, but basically what's happening is most of the mutations happen here. So you've got rapid cell division, lots of mutations being accumulated, but you really don't see cancer until much later in that individual's lifespan. And what seems to be happening is this black box that we call aging or a decline in youthful fitness. So the question is, what is happening here? One obvious thing is our immune systems are starting to not be quite as good, but there's a lot of other things that are happening here that are increasing the risk of cancer. And so you can see this reciprocal decline accompanied by an increased cancer incidence. So one of the things that we realized, that it wasn't really hard if you paid attention, is that when you look at lifespan, you actually see this increase in life expectancy, as I showed you. And what you see is that most of the cancers occur in people after they reach that evolutionarily determined lifespan. And if you take a very extreme example, which is lung cancer in smokers, the actual exposure insult happens here. People start smoking when they're teenagers, and yet cancer really doesn't appear until after they cross this, it's not really a threshold, but it's easier to depict as a threshold boundary of our evolutionary adapted lifespan. So this is where our systems start breaking down, and now cancer becomes possible. So we can think about the fact that we can focus our prevention efforts to understanding what creates a difference between youthful fitness and cancer permissiveness. So we can also say that dogs and humans share one thing in common that is not really common across other species. And that is that when you look at many long-lived species, they are really not different today than they were 200 years ago or 1,000 years ago or even 1,000,000 years ago. Whereas humans and dogs in the last 50 to 200 years have doubled or tripled or quadrupled their lifespan. And if you look, I'll show you this again in greater detail in another slide. But dogs and humans both see this increase in cancer after their evolutionarily determined lifespan, which obviously is not happening in other species where the rate of cancer in their lifetime is similar to what we see in human children, adolescents, and young adults. So the rate of cancer that we see in people from 0 to 30 is the same rate of cancer that we see in virtually every other species when we look at them. And that's somewhere in the range of 0 to 10% of the population dying from cancer, as opposed to us, which is closer to 40%. So what is a systemic cancer risk profile? How can we start thinking about that aging black box? So I showed you that, again, in dogs, we see this a similar trend as in humans. And so this basically looks at a comparison of dogs and the relationship between aging and gastrointestinal non-malignant conditions. So you can see that there's a linear increase. As the dogs get older, they get more things wrong with their gut. But when you look at cancer, this is basically all malignancies. Young dogs get very, very little cancer, and then they cross this sort of boundary where things don't work as well. And you see lots of cancer, somewhere in the order of 20 to 25% of the dogs reaching the senior age being prone to cancer. So we developed this idea that we could identify what this permissive environment was, test for that environment, and rather than just tell people, Mrs. Smith, your dog has a high risk of developing cancer, but go have a nice day, which is not really cool, right? That's the Grail approach. We decided to actually do an intervention. So identify the individuals that were at high risk and do something to mitigate that risk. So the Shy Non-Suspicion test, otherwise known as the SOS test, kind of cute, achieves risk assessment, and the drug EBAT serves as the intervention for interception. So the way that this works is we have a blood sample from a healthy adult dog. We lyse the blood. We label cells to do flow cytometry. We run flow. And then we use AI to characterize patterns that tell you whether a risk environment is there or not. So we used machine learning to do this. Our training set included almost 100 dogs with known conditions. This was focused on a disease called hemangiosarcoma, but tested for other things. And I want to highlight the fact that our healthy population was actually dogs between the ages of 2 and 4. So they were skeletally mature. Cell division had pretty much slowed down, but they were prior to that age of highest cancers. So when we did K-fold cross-training and validation, version 1 of our test gave us a sensitivity greater than 70% across 12 different algorithms, specificity greater than 90%. And one of the things that we've done with AI or machine learning is rather than pick our favorite one that works, we actually repeat the testing across multiple different algorithms that use different approaches in different families. And if we don't get the same answer, then we know it's a hallucination. We have to get to the same place through multiple approaches in order for us to validate this. We did a small external validation study looking at dogs that had hemangiosarcoma, and when we classified where they would fall into based on our criteria, 8 out of 11 dogs were correctly classified as having hemangiosarcoma. That was our training. That's not surprising. 2 of the 11 were classified as having another cancer. That's tolerable. 1 out of the 11 was classified as having a benign mass, and we can explain that. But the important thing is that none of the dogs that have hemangiosarcoma were classified as healthy. So it gave us some confidence that we were doing well. So the next thing that we did is we took 200 otherwise healthy dogs. We ran the test in those dogs. They had to be 6 years old or older, so they're already in that risk environment of being aged. And we asked, can we classify them into high risk or low risk? And then we followed them for a lifetime. So this is a 9-year project, and asked what happened to those dogs over time. So it turns out that our test has an accuracy of about a year and a half. And why is that? Because time doesn't stand still, right? So we test a dog, and if it's low risk today, maybe it'll be high risk tomorrow. But over a year and a half, what you can see is that the low risk category, or what we call not high risk, has less than a 5% chance of developing cancer. Whereas the high risk population starts developing cancer quite rapidly. These are probably dogs that had an undiagnosed cancer that went into the high risk category. But those that had the high risk environment, within a year and a half, about 25 to 30% of them have cancer. So the good news is 70% of them don't. The bad news is 30% of them do. And at this point, we don't really know how to distinguish those. So we think that as we improve our test, we're going to be able to actually achieve better separation. But this gives us something to work with. So what happens if we take these dogs and we use the intervention? So what are we measuring first? So part of the project that was funded by RIS allowed us to do single cell sequencing. We did 8 experiments that included a variety of things. The cells that we're interested in cluster into these tiny little clusters, so they're separate from a lot of other things. They do have a characteristic pattern. And then it basically includes, when we actually do name mapping, it includes inflammatory cells, a subset of monocytes and B cells that are unconventional, some hematopoietic progenitor cells, and then a collection of mesenchymal cells that collectively represent less than 1%, or actually less than 0.1% of the population in the peripheral blood. And that includes endothelial cells, mesenchymal stem cells, fibroblasts, muscle cells, and others. So we asked, what does this pattern do? Where do these cells live? So to do that, we actually use single cell sequencing. And the first thing that we did was dimensional reduction. So this is a t-SNE plot showing each individually sequenced cell as an experiment, along with bulk sequenced tumors, benign masses, and actual tumor cell lines. So we wanted to see if any of the cells we had in there looked like a malignant cell that we could grow in culture, if they looked like a benign thing, or if they looked like things that would be in the tumor environment. So the dimensional reduction told us that there was some clustering, but it wasn't great. So we actually did feature reduction and picked the top 116 genes, and we did AI. So we trained on the bulk sequenced hemangiosarcoma cell lines. We have about 30 of them. Hemangiosarcoma tissues, we have about 80 of them. And then what we call hematomas that are essentially benign lesions, and we have about 29 or 30 of them. So we did training, cross-validation, and then we took every single cell in our single cell experiment that had been done from isolating the cells in that particular environment that I told you about. So we were able to test about 440 odd cells. And what you can see is that virtually all of them fall into the tumor. None of them look like our cultured tumor cells, which represent a wide diversity of the disease. One of them looks like it belonged in a hematoma, but basically all of them, or all of them except one, basically fall into being in the tumor. So we think that these are cells that are actually being mobilized from point A to point B to create the tumor niche, to actually allow the tumor to build a home and thrive. So our intervention really is aimed at tackling these cells that build the tumor home. We don't really care about killing the tumor cells because we're making mutant tumor cells all the time. So because we know that there's cell division and mutation in babies and young adults, and the rate of cancer is really low. The rate of cancer is really low because the tumor can't actually build a home. So if we can actually prevent the tumor from building a home, we might be able to prevent cancer. So we use the drug EBAT. EBAT is a drug that was invented by Dan Valera here at the University of Minnesota. It's a ligand-targeted toxin, so it has epidermal growth factor moiety and the urokinase N-terminal moiety that binds to the urokinase receptor. It uses the receptors on cells as bait to deliver a lethal bacterial toxin. So basically on the affinity that we have, it's really good at killing tumor cells. But interestingly, it's very good at either killing or reprogramming inflammatory cells in the tumor environment and actually activating the immune system. So the question is, what happens if we give EBAT to dogs that are at high risk? So this is a line that I just showed you. These are essentially our controls from the test. And these are dogs that we've recruited over the last 4 years or so, where if they were high risk and they met some criteria, we actually found that there was no detectable tumor based on state-of-the-art imaging. We actually gave them EBAT prevention, and we asked, what happens to these dogs? So we actually lost one of the dogs 2 years after EBAT to cancer, but basically this is a small experiment. I think we've enrolled about 14 dogs to date, 13 or 14 dogs to date, but this is what the curve looks like, right? So these dogs are not dying of cancer. And the protection seems to last for years. So we're out, some of the dogs are out over 2,000 days. So of course the question is, is our population biased? Do we have a selection bias? So our next goal is to actually do this as a randomized blinded test to make sure that it is the intervention that's giving us this exciting result and not purely selection bias. So one of the other really cool things is that as we talk to the dog owners, they say, this is something we never expected. First of all, we didn't expect that our dog was not going to die of cancer because we've had this experience before, et cetera. But they said the dog came home and within a week, it started being really naughty. It started jumping on the table. chasing its friends, going swimming, doing things that the dog hadn't been doing for, 3 or 4 years since it was sort of a puppy. And we haven't quantified these. We didn't really expect to see this, but we are getting these repeated anecdotal reports from the owners of these dogs that this drug is doing something that is altering the systemic environment of these dogs and might actually create a perception that they are not acting as old as they were before. So it actually might fulfill, this approach might actually fulfill our idea of not only preventing cancer, but actually promoting graceful aging. So in conclusion, the loss of youthful fitness, defined by the development of these systemic patterns of mesenchymal inflammatory stem cells in the circulation, might create a favorable environment for cancer to arise. The cancer permissive environment is associated with an increased rate of malignant cancers in dogs, including life-threatening sarcomas. And pharmacological modulation of this environment, we believe, is a feasible approach to reduce the cancer burden. So hopefully, I was able to at least get you to recognize that youthful fitness and the loss of youthful fitness is part of creating a favorable environment for the emergence of cancer. Told you a little bit about how this cancer permissive environment forms and what's included in it, and appreciate that if we can alter this permissive environment, we can actually reduce the incidence of cancer. So again, secondary prevention or interception is feasible and might be an effective method to reduce the cancer burden. And we should remember to include graceful aging as a key component and a major goal in our cancer prevention efforts. So the people who did the work, Taylor really took this on when she started in our lab, did a ton of work. She is now a stellar graduate student with Steve Jameson. Ashley runs my lab and has taken over the project and truly remarkable creative individual. Mitzi manages all our connections with the outside world. Amber basically is in charge of all the treatments. Ali does our machine learning. Caitlin and Antonella supervise the CIC. Mike is one of our oncologists. Aaron is our conscience that always comes up with being the devil's advocate about why we're wrong. And Gary, who supports all our statistical work. So with that, I do want to highlight the role of Rein in sarcoma in funding a lot of our work. This particular project has been funded for long-term from the Canine Health Foundation, Portuguese Water Dog Foundation, the Boxer Foundation, and the Golden Retriever Foundation.
All right, so there's time for a few questions for Jaime. I'll bring the microphone to you if you have a question. Maybe I'll start with one. I thought you were gonna say you're intervening in these dogs with some kind of antifibrotic or anti-inflammatory. That would be another possibility. I think that EBAT sounds like a pretty potentially harsh drug to give people who might be at high risk of cancer because it's like a cancer.
They don't target it.
But I think people might consider the right combination of antifibrotic or anti-inflammatory nutraceuticals. It's something some of us here are interested in, something we're testing in the NF1 population, which is sarcoma from, with Dr. Starak, who's over here actually. So curious to hear what you think about that.
Yeah, I agree. I think that EBAT would have a low barrier to being applied as a cancer interception in dogs. You have a lot of data showing that it's safe. And there's a huge demand. The drug is licensed by a company, and we get hundreds of emails every week saying, "Why can't my dog get it?" But we have heard repeatedly. We haven't actually talked to FDA, but we've heard repeatedly that this would be a non-starter as a prevention drug. So our thought was actually to approach the problem metabolically rather than antifibrotically. So we've been having conversations with some groups to think about how we can approach a problem metabolically. But there's probably many ways to get there. And if the approaches that you guys are using would also be able to sort of retard or revert this environment, it might be great. So maybe something that we should discuss.
Absolutely.
Thank you, Jaime. Let me just say, you're like a dog on a bone with this, and you're not barking up the wrong tree. You know, I'm friends with you mainly so I can make dog jokes.
Absolutely.
But also just to bring it back to sarcoma, and you know, your graph for your friend who's talking next week. And but anyway, I just want to point out to the audience that sarcomas are rare because the tissue, one of the major reasons is the tissues that they form from largely don't divide over the lifespan, right? So you're born with basically all your muscle cells. And if you get swole, that's because the cells get larger, not because they've divided. And same with being born with most of your lipid cells, right? And they don't divide if people gain fat. It's just that the cells actually literally get larger. So I just wanted to point that out to all the people wondering, why is sarcoma so rare? And that's the meta answer.
Why is sarcoma so common in mice and in dogs?
Maybe those
Because
cells
they have-
divide in those animals.
Well, I think that, I think that's a very keen observation. However, we do know that mesenchymal progenitors in the bone marrow continue to divide over the lifespan of an individual. So some differentiated tissues don't have a lot of turnover, but the actual progenitor cells do. And so I don't know. I think trying to blend the epi and the biology is really important. And I think much like when we really started talking about this extension of lifespan, I haven't actually gotten a lot of pushback. I think most people have said this is really thought-provoking and fascinating. Hadn't really thought about that before. I think we don't understand a lot about what's going on because we haven't actually taken a step back to think about whether the dogma is right. And sometimes being anti-dogmatic is not fun, but it's necessary. And I'll just say, sort of retorting to Logan, ever since I told him that we had one of our favorite dogs was named Logan, he's always decided that he has to get back, and he said he was going to name his next dog Jaime, which would be an honor.
All right.
David.
Thanks so much, Jaime. All right, so our next presenter is Dr. Chris Ann Schultz, the Pine Tree Endowed Chair in Cancer and Blood Disorders Research at Children's Minnesota, and she will focus today on DICER-related sarcomas. So thank you, Chris Ann.
Thanks so much, David and Michelle, and to all of the organizers of this great event. Thanks to all of you for being here, and special thanks to all of the Rein and Sarcoma supporters who've made so much of the research that we'll discuss today possible. It's just such an honor to be here today and to talk about our updates in DICER-1 related sarcomas at this 25th, celebrating these 25 years of discovery at this 2025 symposium. Here are our standard disclaimers. I don't have any conflicts of interest to disclose. My hope today is that this talk will help facilitate recognition of DICER-1 related cancers in clinical practice, provide some clinical and laboratory updates for DICER-1 related sarcomas, and especially highlight research made possible thanks to Rein and Sarcoma support. Now, as many of you have heard me say before in this venue, PPB, or pleural pulmonary blastoma, is the most common lung cancer of infancy and early childhood. And these truly are young children. About 92% of children with clinically significant PPB are diagnosed before 7 years of age. And like other sarcomas, the malignant component of PPB derives from lung mesenchyme. And we recognize 4 main types of PPB, which are shown on this slide here. You'll see far to the left, type 1 PPB. It's a purely cystic lesion, but don't be fooled. If you resect it and look at it under the microscope, you'll see this component of primitive, often rhabdomyosarcomatous malignant cells. And if those rhabdomyosarcomatous or primitive malignant cells grow and proliferate and partially fill in that air-filled space, that's type 2 PPB, mixed cystic and solid PPB. And if those bad cells continue to grow and proliferate and they completely fill in that space, often resulting in a very large mass, which may even shift the mediastinal structures over to the side, that's what we term type 3 or completely solid PPB. So we know that type 1 PPB can progress to type 2 PPB, can progress to type 3 PPB. And we can see that radiographically. In fact, the top images are from the same patient. The first X-ray, chest X-ray, obtained incidentally when they thought the child had swallowed a coin, although you can see there that they had not. That lung cyst was not recognized. That lung cyst was not recognized. Then the child presented a couple of years later with what was thought to be pneumonia, was treated for a few months with antibiotics, failed to improve, a few weeks with antibiotics, failed to improve by 2 months later, and then had a subsequent chest CT, which showed that completely solid lesion. So we can see that radiographically. We can see that under the microscope in the images below, the photomicrographs. And we can also see that epidemiologically with the median age of diagnosis for a type 1 PPB being only 8 months, type 2 PPB 36 months, and type 3 PPB diagnosed at a median age of 41 months. So we know that progression happens, but we also know that progression is not the universal fate of all type 1 PPBs. And that lower part, that type 1R PPB there, is perhaps the most common form of PPB. Those malignant cells have somehow withered, have somehow gone away, they've somehow failed to progress or regress, leaving this air-filled lesion by chest X-ray or by chest CT, but without any malignant component under the microscope. And we know that type, not surprisingly, based on what I've just said, correlates with prognosis. So type 1 PPB is associated with an overall fairly good prognosis, 3-year event-free survival of 93.4% and an overall 3-year survival of 100%, whereas outcomes are considerably poorer for children whose PPB has progressed to type 2 or type 3. Now, from the very early descriptions of PPB in the late 1980s, there was evidence for familial predisposition. So you'll see here a pedigree or a family tree or family kindred showing 2 brothers with type 1 and 1R PPB respectively, whose paternal grandmother had thyroid nodules, had a pituitary prolactinoma, and had a very unusual type of ovarian cancer, ovarian sertoli cell tumor, resected at 32 years of age. So from family trees like this, genetic studies were then done showing that DICER1 is the key gene underlying the development and risk for pleural pulmonary blastoma, as well as what we now recognize to be a wide spectrum of other DICER1 related cancers. And these DICER1 related cancers include several sarcomas, which I'll talk about next. So let's talk about kidney tumors in DICER1. The most common kidney tumor in DICER1 is cystic nephroma. That's a benign, quite cystic tumor. You'll see it in the CT scan image there, seen in about 10% of families who have PPB. And there is a risk that the cells in a cystic nephroma can progress and develop into an anaplastic sarcoma of the kidney. So generally, we do resect these cystic nephromas when they're found. There is some risk for bilateral disease, so we're working to understand how often that occurs so that we can plan for the right surgery, be that a complete nephrectomy or a partial nephrectomy based on that risk. And we know that early resection, which is accomplished generally by surveillance for these tumors, may be nephron sparing, may spare healthy kidney tissue from surgery. So in addition to cystic nephroma, we also recognize 2 types of malignant tumors as associated with DICER1, including Wilms tumor, a small set of Wilms tumor, and anaplastic sarcoma of the kidney, the latter being generally DICER1 related. Gynecologic tumors are also a classic manifestation of DICER1. We recognize sertoli cell tumors and gynandroblastomas, which may present with hormonal symptoms that may include changes in the menstrual cycle or virilization. And nearly all of these tumors, if you look at their somatic testing, are DICER1 related, about 50 to 60% in the context of germline predisposition. So about half the time, these DICER1 related cancers arise outside the setting of identifiable germline predisposition. And importantly, while sertoli cell tumors themselves are not sarcomas, they often may have sarcomatous elements. And some recent research from our group shows that these sarcomatous elements are associated with a particularly poor prognosis, so an important subject of future study. In addition to the sertoli cell tumors and the gynandroblastomas, DICER1 may also be associated with primary ovarian sarcoma and cervical embryonal rhabdomyosarcoma. PPB-like peritoneal sarcoma is another DICER1 related manifestation that's more recently described. Now, these cases didn't just recently come into being. They were previously just called sarcoma and not otherwise specified. Sarcomas who quite surprisingly had these both cartilaginous and often rhabdomyosarcomatous components found within the abdomen. And so far, we've observed 3 forms of this in parallel to what we see in the lung, similar to the type 1R PPB and type 2 and type 3 PPB. Central nervous system tumors are thankfully rare within the context of DICER, but include pituitary blastoma, pineoblastoma, CNS sarcoma, now called primary intracranial sarcoma, DICER1 variant, ETMR-like tumors, and perhaps the most common DICER1 associated tumor found in the central nervous system, unfortunately, metastatic type 2 or type 3 PPB. So to further understand these tumors, the International PPB and DICER1 Registry was founded with the original registry. The International PPB Registry was founded in 1987, just down the road at Children's Minnesota, and has now enrolled more than 1,400 individuals, 153 of those in 2024, very busy year for our team, from 600 institutions throughout the world, including 49 US states and 60 countries. This registry includes individuals of any age with any of the DICER1 related conditions known or suspected, although most patients end up with a confirmed diagnosis, and or germline DICER1 variants. You don't have to have both because we think really understanding those tumors which arrive seemingly sporadically, although perhaps not actually sporadically, is just as important as understanding those in the context of germline predisposition. The mission of our registry is to improve outcomes for individuals with these tumors through these 4 strategic pillars. First, defining optimal therapy. Second, validating our testing and surveillance guidelines and improving those over time. Third, developing new ways to diagnose and follow children with these tumors. And fourth, and one I feel particularly passionately about, discovering new therapies for DICER1 related cancers. So in the last year, there have been several advancements across these types of sarcoma, and I've highlighted the specific sarcoma-related projects here for which there's been significant progress in the last year. This includes efforts related to all types of PPB, including the development of a prospective clinical trial, which we'll talk about in a moment, ovarian sertoli cell tumor and gynandroblastoma, especially highlighting the risks posed by those sarcomatous elements, anaplastic sarcoma of the kidney, publishing the largest ever series for those, which we talked a little bit about at last year's Rein Sarcoma Symposium, and work in ovarian sarcoma. So I hope I convinced you the first time I showed this slide that it's really important to find these tumors early, that if we can find these tumors at their type 1 form, we can really improve outcomes. So this is not new to this room. This room is very invested in early diagnosis for sarcomas, but it's worth saying out loud that many sarcomas overall, and DICER1 sarcomas specifically, are most curable when found in their earliest form. So much so that we actually made it a registry hashtag, which Melissa there is helping us share with the world. So these tumors, which can be result in an improved outcome with less toxicity, include PPB, anaplastic sarcoma of the kidney, and ovarian sarcoma, among others. And this is really critical for all individuals with sarcoma, but I'll call special attention to the issues in young children related to the long-term side effects of therapy, which we'd really like to minimize through early diagnosis. So in 2018, we published the first ever set of surveillance guidelines for individuals who are identified as having risk for this particular set of sarcomas based on their genetic testing, individuals who had a germline pathogenic or likely pathogenic DICER1 variant. And I've been saying ever since 2017, 2018 or so, this is just where we're starting. We really need to continue to collect data and optimize these surveillance guidelines over time. And I'm so happy now to tell you about advancements in that work. So since 2017, 2018, when those guidelines were assembled and then published, we've continued to enroll individuals with DICER1 variants and these other conditions. And then for this analysis, we combined that data with data from the NIH Natural History Study led by Doug Stewart. And this resulted in a cohort of 713 individuals with confirmed germline pathogenic or likely pathogenic variants in the DICER gene. We excluded individuals with mosaicism as they tend to have a different phenotype. And all in all, this is a worldwide effort with 38 countries represented by this data set, which I'm so glad to tell you showed that early detection both matters to patients and families and is feasible. So our lung data. So our data for the most classical of all DICER1 sarcomas, PPB, we showed that 5 type 1 PPBs and 29 type 1R PPBs were detected by surveillance and resected, again, in their earliest and most curable form. There were 2 separate incidences from that, which I think are worth calling attention to separately. One was a child who had a type 1R PPB diagnosis and was being followed with disease-specific surveillance for that diagnosis, who then developed a very small type 2 PPB, which was resected and successfully treated, and a child who sadly was being followed for a very large and growing lung cyst. Those usually would have been resected, but for various reasons were not resected, and that child then presented with a type 3 PPB. But apart from those 2 cases, there were no other cases of type 2 or type 3 PPB diagnosed in individuals who are undergoing surveillance. Kidney tumors, we have in the registry overall 73 individuals with DICER1 related renal tumors. Nearly all are cystic nephroma, as we would expect from our historical data. But there are also 7 cases of Wilms tumor, all DICER1 related, as well as anaplastic sarcoma of the kidney, seen in 4 patients over a wide age span from 1 to 23 years. And 8 of those tumors, 7 cystic nephromas and 1 Wilms tumor, happily a stage 1 Wilms tumor, were diagnosed by surveillance. The data for the sertoli cell tumors was particularly interesting. And for this data set, we combined sertoli cell tumor and gynandroblastoma together, which is consistent with current guidelines for pathologic diagnosis. And notice that they were diagnosed at an earlier age than we would have suspected based on our prior data. So again, this data set is 713 individuals, all with germline Dicer 1 variants. And while our initial guidelines showed that pelvic surveillance should begin at age 8, we noticed that 13% of these ovarian sertoli cell tumors and gynandroblastomas were diagnosed under the age of 8, the age at which pelvic surveillance had been recommended to begin. And 4% were diagnosed before the age of 4 years, with 11 patients developing metachronous SLCT at some point during their journey, a separate distinct primary tumor on the other side. And overall, it's lost in the blue down there a little bit, but overall 15% of the ovarian tumors we saw, so including the sertoli-related gynandroblastoma tumors, as well as the pure sarcomas, were diagnosed under the age of 8. So this led really to a revision in our guidelines. Now, do we expect that surveillance would make a difference? We're asking people to have a lot of ultrasounds over a long period of time. Does surveillance matter? So since 2018, 87 participants with SLCT have been identified, 43 who had confirmed germline pathogenic or likely pathogenic variants. And 10 of those 87 had their SLCT diagnosed by surveillance prior to symptom onset. 9 of 10 of those were diagnosed at a stage 1A, which is a much more favorable stage than the subsequent staging. And only the one patient out of the 10 who was diagnosed as a 2A required chemotherapy. So this led to both increased likelihood of being resected at stage 1A, which is very important prognostically, decreased likelihood of requiring adjuvant chemotherapy. And you'll see at the bottom there also an overall improved prognosis. So SLCTs are most curable when found at stage 1A. Surveillance does seem to find them more often at stage 1A. So this resulted in a change to our surveillance guidelines, moving the initiation of pelvic surveillance to the time of diagnosis. So of course, this data set can't comment on the likelihood of tumor development. A lot of these folks were ascertained and enrolled based on their tumor history. So it should not be construed as the risk of tumor development. And this data set really doesn't tell us how these patients should then be followed once they have a particular tumor. But I do think there's some important information here about the age range of risk for these patients and the stage at which they're identified. But we do need to identify individuals who have this germline predisposition in order to get into this setting in the first place. So this new set of guidelines, this set published in December of 2024, and this set just published last month, which summarizes the previous set of guidelines, now include earlier initiation of pelvic ultrasound compared with the first set of guidelines, with the remaining guidelines essentially unchanged. This manuscript now also includes updated testing criteria based on our expanded understanding of the tumor spectrum associated with Dicer, and a framework for who should be tested, or in many cases retested, if they'd had negative findings. Now, it doesn't matter if we just write this down and put it in a journal somewhere and it doesn't get to the people who need this information. So we hope that by sharing this in medical journals and at conferences, medical professionals will be able to access this information, but we also really need to make sure that it's accessible to families. So to that end, the team worked really hard to devise these family education documents, which are now available to anyone who would like them. And I'll talk a little bit in a moment about our newsletter efforts and our family meeting and scientific symposium efforts to which you are all invited. We do know we need novel ways to detect these tumors, and Rein sarcoma has been a strong supporter of this work. I presented some of this data last year, so I'll just go very quickly through the slides. But this work with the Dicer 1 panel validation and ongoing testing has continued throughout the last year, allowing us really to lay the foundation for some of the genotype-phenotype analysis we're trying to do with Dicer particularly, and helping to support the non-PPB sarcoma-related ctDNA collections for some additional novel diagnostic development. So this work that's supported by Rein sarcoma has really allowed us to expand our understanding of Dicer 1 related tumors. Testing that hotspot, which is something we're doing with Rein sarcoma support, truly allows us to identify whether a tumor is Dicer 1 related or just seen in this context by coincidence. Can sometimes help us detect a recurrent for metachronous tumors. One of the calls I had this morning before coming to this was about a young woman who presented with a very large chest tumor. And the question is this a primary chest tumor, or is this a relapse of a tumor she had 1.5 years ago? And hotspot testing through assays like this is the way we're going to get to that answer. And also the research specifically supported by Rein sarcoma, again, is relevant to these genotype-phenotype analyses, which are currently underway. An exciting update from March, just last week, week before last, March 17th, is that our first ever prospective study for the treatment of PPP has now been launched. It was activated on March 17th. It is now testing the addition of topotecan for type 1, type 2, and type 3 PPP and standardizing the administration of chemotherapy in addition to surgery for children with type 1 PPP, which we hope will cut chemotherapy administration for these infants by about half, from about 40% to about 19%. We're also submitting a new analysis of the role of RAS pathway alterations in Dicer-1 sarcomas, and specifically have some concern for the resistance mechanisms that may underlie treatment response in those patients, which we hope is also launching a larger collaboration of the Hopkins sarcoma and RAS teams. And the work that you guys have supported has really helped us with them. In addition to our Dicer-1 related work, Rein and Sarcoma Funds at Children's Minnesota have also supported our participation in this Edison Consortium, which focuses on Lee-Fraumeni syndrome and is very synergistic with our Dicer-1 related work. Our March update on this one is that our DoD grant submission was recently recommended for funding. So we're hopeful that that will proceed, as the email currently states, with funding. But I just really want to highlight how much Rein and Sarcoma support has been foundational. Look directly at you and I say that, Lachelle. Rein and Sarcoma support has really been foundational in developing the pilot data that allowed for submission of that DoD grant. And I've talked a lot about early diagnosis today, but I think it's important to say that not all Dicer-1 tumors are going to be amenable to early diagnosis. We could get to 100% adherence to these kinds of surveillance guidelines, and there would still be a wide range of tumors that we may miss for lots of reasons. One of them, including that these tumors do not always arise in someone with identifiable genetic predisposition to Dicer-1 related cancers. So we still need to work very hard on the development of novel therapies, and those efforts are very much underway. One of the things we launched in the last year, in addition to our existing PDX program, was organoid testing for conventional and novel therapeutics. So I hope the take-home messages from today will be that for Dicer-1 related cancers, diagnosis in their earliest and most curable form is a key clinical priority. That depends on being able to see the clinical pattern when it presents itself, a family history of some of these tumors or a particular tumor presentation, but also depends on all of us working together to spread that word. I think science is super cool and fascinating, but one of the things I've really learned through this research is that interesting is not enough, that we have to actually turn what we find fascinating about all this into direct help to kids and families. And every journey matters. Each time a patient participates in this research, or a researcher, we collaborate with a researcher, we learn something that contributes to this. And as we've learned from so many patients, but one that sticks in my mind in particular, who taught me this phrase, knowledge is definitely power when it comes to all of this. So on that front, we are hosting May 6th of 2025, a Dicer-1 Registry Scientific Symposium. We always host the Registry Scientific Symposium in May, but this year as a new thing, we're merging it with the family meeting, which we usually hold in August. The reason is that with the new release of those surveillance guidelines, we really want to get that information to everybody's hands at the same time, as soon as possible, and not tell all the doctors and researchers in May and then tell the families in August. We really want to tell everybody at the same time. So that'll be a combined meeting. It'll all be held virtually, and we hope that you will join us. So if you don't already have an invitation in your inbox, please feel free to email us. And then we're also working very hard, as I said, on spreading the word. And Melissa Abraham, who's in the audience with us today, has been a huge part of that effort through her social media, her meeting organization and coordination, and also through these newsletters, which are shared with both referring physicians, collaborating researchers, and families. So this is the latest one. It has registration links. We would love to send it to you. Includes a plug for our patient parent advisory board, because we think that's a really important part of the work that we do. And I'd just like to highlight this part. Dr. Alex Nelson, who's one of the Rein and Sarcoma scholars, is also featured in our last registry newsletter for the great work that he did related to Sertoli Leydig cell tumor, and especially the determination of sarcomatous elements as being associated with a particularly poor prognosis, which is a practice-changing finding in terms of how we address chemotherapy versus observation for those patients. So thank you, Rein and Sarcoma. Looking again over at this table here and others, for your support of the Rein and Sarcoma Scholars Program. So, as I hope has come through with this, cancer research is really a team sport. We're so fortunate to work with so many wonderful investigators and collaborators at so many institutions throughout the world, and this list of folks here who directly work on the registry. And of course, our many patients and families who both inspire this research and make it possible. So thank you so much, Rein and Sarcoma, for all of your support, and to all of you. Happy to take any questions.
For Michelle. Are there any biomarkers that would enable
germline isoforms to be detected underneath the screen.
The germline variant itself. So there are other things for which we do surveillance, for which we do newborn screening. And I think one of the tricky things about Dicer is that loss of function variant that is often a predisposing mutation really in a lot of different places throughout the gene. It's not like cystic fibrosis where it's free for this one and after X% of people. But I think today's technology, there's no reason we couldn't do it as we reach. But honestly, talk about that a little bit further. I think it's a fascinating idea. Same thing with retinoblastoma.
I don't know if you've kept up, but there's a lot of studies coming out of newborn whole genome sequencing. So newborn screening is going to move that way in the next 5-10 years, no matter what. So yeah, you should definitely hop on that train.
I love that idea. I think that would be great. We discover a lot more lung cysts and we have to figure out what to do with them, but they didn't know this.
Yeah, this company called Ultima Genomics says they have $100 50x genome now. So yes, it's technically feasible and not that expensive. Sequence everybody.
So what happens after you treat successfully? Are these kids, as they grow older, still at risk for lifelong new tumors?
They are sort of. So if you look at the incidence curve, it really, apart from thyroid cancer, which is differentiated thyroid cancer, generally localized, associated with a good prognosis, that curve really flattens out. For males, for sure, it flattens out. Without the ovarian tumors, that curve is fairly flat after childbirth. And then for women, it goes up with ovarian tumors, but up still only about 5 to 10% of women with Dicer will ever develop an ovarian tumor. So it's still a fairly flat curve. Just depends on how you stretch the y-axis. So I think your point is well taken, but these occur at very specific developmental time points and relevant to the conversation we just had about the muscle cells and when they divide and when they don't. The PBBs happen age 7 and below, which is when the lungs are dividing and doing all the things that the lungs do developmentally. And the ovarian tumors happen, well, I just made a case that we should do pelvic ultrasound for age 8. Yes, most of them still occur between about age 8 and 25 when they're turning on and coming online and being active. So I think it's not likely from any, for example, where you see accumulation and higher instances of cancer as things go on. I think there has to be a particular developmental window where the second hit perhaps, or third hit or fourth hit. We didn't talk about P53 or arrest very much during this talk, but those would be common additional hits in addition to the 2 hits and Dicer that we see. There must be a developmental window.
All right, thanks so much.
Thanks so much.
Okay, so our next speaker is Dr. Leighton Elliott, an assistant professor of medicine and pediatrics at the University of Florida. Dr. Elliott is also the director of the Adolescent and Young Adult Cancer Program at the University of Florida. Dr. Elliott will delve into the cutting-edge topic of mRNA vaccines for sarcoma. This presentation is virtual, but let's give a warm virtual welcome as we prepare for his presentation.
Can you hear me and see my screen?
Yes, we can.
Okay,
Take it away.
all right. Thank you for having me. Thanks, Lachelle, for the invitation. I met Lachelle at a conference and we've kind of been in communication. It's only been, it's probably been about a year now. I'm excited to be here and present some of the work that we've done. So thank you for the introduction. In our lab, we study mRNA vaccines, and I'll talk a little bit more about that. But first, I want to talk just briefly. I assume this crowd knows what sarcoma is, so I'm not going to go into any detail, but we know that sarcoma generally likes to metastasize to the lungs. And this is just an example of obviously a pretty devastating case. And so pulmonary metastases is something that we study in our lab and hope to cure with our treatment. mRNA vaccines, by this point, all of you have probably heard about COVID-19, the pandemic, little thing. And during that time, we obviously there was a heavy focus on trying to find vaccines and treatments for COVID, and mRNA vaccines became successfully enacted into our clinical care of COVID-19. And this is just a simple structure of what it looks like. You take the spike protein and then you basically can encode mRNA and then put it into a lipid nanoparticle. And then that lipid nanoparticle can can release that mRNA into our bodies to be able to produce that small protein so that we can then develop immunotherapy against it. Sorry, is there a question? No? Okay, sorry. So our bodies will naturally develop a response against whatever is encoded in this lipid nanoparticle, and we can feel comfortable that this will not get integrated into our nucleus, into our DNA, that it's transient, and then mRNA dies very rapidly by endonucleases in our body. And so from that, we've had a rapid development of other uses for mRNA vaccines. Now, keep in mind, mRNA vaccines have been around for a very long time. Our lab has been studying them for about at least 15 years. It's just during COVID, there was a discovery, a Nobel Prize winning discovery, that allowed us to improve the way we use them. And so now we have some people who have really focused on using them for cancer. We have almost 40 active clinical trials using mRNA vaccines for cancer. And here, Merck, Moderna, and Pfizer have collaborated to use their vaccines for cancer in different venues. So pancreatic cancer, they showed some fairly good responses, and same with melanoma, and there are some others that they're studying. But we know that the big drug companies don't really focus on sarcoma, and that's sort of where we come in. And with that, we also, it's the same idea with brain tumors. And so our vaccine here in Gainesville is a little bit different. Our vaccine is more immunogenic in terms of the innate immune system. And we use this multilamellar structure, lots and lots of layers like an onion, and they form into aggregates, which stimulates the innate immune system, which then activates the TME, which was mentioned earlier. The innate tumor microenvironment then turns from a cold tumor microenvironment to a hot tumor microenvironment. And so typically in brain tumors and in sarcoma, we can't just give immune checkpoint inhibitors because of this cold tumor microenvironment that's resistant to change and to immunoresponsiveness. And so it's important that the way we see it, at least, is that we turn on this, what we call danger signal, and activate the immune response. And so we've shown this in mice. We treated osteosarcoma and brain tumors. And we've shown here, you can see this Kaplan-Meier curve, this blue curve. The mice are living longer compared to when they're not treated, or if they're treated with a control. And then we showed the same thing in canines, companions, like the first speaker mentioned. So we also have a veterinary school here we work collaboratively with. And we have multiple clinical trials for dogs and cats, using not only our treatments, but others, but immunotherapy for cancer. And so we showed here that in dogs with brain tumors, we do get a similar response where we're able to flip the tumor microenvironment when given neoadjuvantly. And then this dog actually showed, this dog got radiation therapy, and they showed a significant response to treatment. And you can see here where our dogs in this group were showing some survival benefit over time who were treated with our vaccine. And so that led us to an FDA IND approval, and now we have multiple clinical trials using this mRNA vaccine in humans. And so this is an example from our first 3 patients where we gave them our vaccine, and we were able to see an a drastic immune change in the peripheral blood. And this is what we expected. And you can see here where you see mobilization from the peripheral blood to what we expect is the tumor site of the immune cells. And so now we just opened a clinical trial. We just enrolled our first patient. I'm sorry, move this share screen here. Oops. Okay. All right. It's okay. So we just enrolled our first patient in this osteosarcoma trial. And here you can see it's multiple arms. And we're very excited about this because it's a first of its kind for osteosarcoma, which drastically needs innovative treatment therapies for patients with metastatic disease. As you all know, the outcomes are pretty dismal. And so in patients who have pulmonary metastatic disease, the idea is we're going to study the tumor microenvironment and the responses from our therapy. And so if the patient has unilateral resectable disease versus bilateral resectable disease versus unresectable disease, they can all be enrolled within the study. And we need a tumor tissue to create the vaccine. And we take that tumor tissue and we basically crush it up and extract RNA and what we call total tumor mRNA. And then we actually give it 50-50 with this PP65 mRNA. PP65 is found in cytomegalovirus, which is basically inoculated in everybody. But we found that this is present in glioblastoma. And so we found that when we use a vaccine that's nonspecific, we do get a similar innate response. And so here, while we're waiting for our vaccine to be created that's personalized to the patient, we use this PP65 vaccine for the first 1 to 3 cycles every 2 weeks of the vaccine. And then we would, once we get the personalized vaccine, we would give that to the patient 50-50 with the PP65. And we're also giving this in high-grade glioma clinical trial as well. So this trial just opened. We're enrolling the first 4 patients here at University of Florida, and then it'll be opened up to other centers nationally. And so what I'm interested in is rhabdomyosarcoma, and so we decided to kind of start from the beginning and see if we could model rhabdomyosarcoma in mice and then provide a treatment, because as we know, rhabdomyosarcoma is a terrible disease. It's challenging to treat, and it, again, desperately needs innovation. And so this M39M mouse model is we inject the tumors IV via the tail vein, and those basically go straight to the lungs and grow in the lungs. And these mice, 100% will grow tumors, and 100%, if they're not treated, die within 25 days. We vaccinated these mice. You can see here the first 3 vaccines are within the first week, and then we do weekly vaccines. And we collected blood after the 4th vaccine to see if we're getting that immune response. As we hypothesized, we do see a survival benefit that's statistically significant. And so in red here, the mice treated with our total tumor lysate, just tumor crushed up vaccine, they did live longer compared to mice treated with a non-specific mRNA vaccine, and definitely compared to the untreated. And here you can see that these basically are some of the significant cytokines and chemokines that we saw when we collected the blood from these after the vaccine treatment. And you can see here that we're still seeing significant interferon response and cytokine and chemokine response. And one thing we wanted to make sure is that when we do give our vaccine, that we are able to create long-term survivorship. And so we want to make sure that we have adaptive immunity. And so what we can do is take, again, somebody mentioned tumoroids or organoids. We can take the cell line and just kind of create spheroids in culture. And we vaccinated some mice, we collect their spleen, and then we co-culture those vaccinated cells with the spheroid and see if we can have an effect. And that would tell us if we have adaptive immunity. So without any vaccination, these tumoroids grow. These are just kind of crude images of tumoroids. And you can see that it nearly doubles in size in 2 days. Whereas when we do have these vaccinated T cells, these are splenocytes in a 10-to-1 ratio, then you can see the tumor basically disappears within 12 hours. And here is a bit of a better image of this is a tumoroid. So this is a tumor collected from a mouse. And we can bioprint T cells around the tumoroid. And we work collaboratively with our engineering colleagues who help us with these 3D printing. And we can see that you have expansion of the T cells here. And you can see invasion of the T cells into the tumor, and they kind of get larger in different little groups. So we definitely have migration, and we have some data to show we can track these T cells and show how they move over time and migrate and infiltrate into the tumor. And so these long-term survivors that we had, we decided to re-challenge them. We gave them, so to again confirm that we're getting adaptive immunity, we re-challenged them. We gave them the cells again, and this was almost 2 months ago, and they're still they're still surviving. And so ideally, when we vaccinate somebody against the cancer, they have long-term immunity and they're cured of this cancer, and potentially avoiding them from toxic chemotherapy that we know has what effects that has on people. So this is very exciting data. And now, one thing that we want to do, this tumor lysate, total tumor mRNA, is it kind of takes a conglomerate of tissue, so it can include some normal tissue in it. And so we think that we can target tumor cells better. And so the question is, how do we do that? So if we go back to some early data, we see that this H3K27M, this is an antigen in midline gliomas. And so we showed that if we target this specifically, that we actually do see a response instead of doing the total tumor mRNA. And we also found that, okay, in sarcomas, in a lot of sarcomas, we have fusions. And so we took several different cell lines and we just showed that first, okay, can we identify the fusion and isolate mRNA? And we showed that, yes, we can identify the mRNA in various different types of fusions. Ewing's, 2 different types of Ewing's, clear cell sarcoma, non-small cell ALK fusion, non-small cell sarcoma, carcinoma, which is adult lung cancer. And what we showed also is that if we take, again, the same idea of the spheroid, if we take the spheroid and we co-culture it with T cells from a mouse vaccinated with a fusion-specific vaccine, then we do see some tumor killing. And so we're again showing that we can target our vaccine even better. And here, this is what I was alluding to earlier. We can show that the T cells migrate and do infiltrate the tumoroid or the spheroid. And so my passion now as a physician scientist is to translate this for rhabdomyosarcoma. And this is where I'm hoping the Rein sarcoma can help us, is with developing a clinical trial for soft tissue sarcoma in adolescent young adults. And we would have a fusion positive rhabdomyosarcoma arm, fusion negative, and then a non-RMS arm. And similarly, we would use this PP65 vaccine in these fusion negative and the non-RMS STS, because we would use the total tumor personalized mRNA vaccine. But in fusion positive RMS, we would use a fusion-specific vaccine, whether it's PAX3 or FOXO1, depending on what the patient has. And this would be an unresectable or metastatic disease. And we would give the vaccine and then evaluate response. And if the patient isn't responding, then we could switch over to the total tumor. And if they do have a response, we could even consider local control and potentially cure patients. And so what about sarcomas or other malignancies that are fusion negative? And what happens when we give a vaccine and then the tumor comes back? And so one of the issues that we run into is that we know that these tumors can mutate and change over time. So we don't want to go and every time a treatment fails, it's not feasible or it's not reasonable always to go and get another biopsy. And so one thing that we can do is work with something called circulating tumor cells, which is the cells that are in the blood floating around that we can capture from someone's peripheral blood. Now, this isn't easy. You could probably get about 30 cells in one blood sample, about 30 mLs. So out of 30 million cells, we might be able to get 30 cells. And so this takes some expertise to do. And we believe that we have developed that expertise using this model where we can collect peripheral blood and we can do some what's called negative selection. We remove some of the white blood cells. We can label the circulating tumor cells or the cells that are left, and then we can use this proprietary microfluidics device to capture the specific cells. We were able to show that we can do this at Ewing sarcoma. And then once we select those in our device, we can use this tool called a cell selector. We can go and pick out the single cells, and once we collect those, even if it's 10 or 30 of them, we can extract the RNA from them, create a cDNA library, and then develop an RNA nanoparticle vaccine to then give the patient. So over time, if the cancer is changing, we can collect these CTCs and then give the patient a different mRNA vaccine to continue to cure the disease. And we showed this in some mouse studies. These are some early studies that need repeating, and we need to do some more work on. And so this isn't ready for clinical trial just yet. However, we're continuing to develop this process, and we've shown that with the CTCs, we have similar efficacy compared to the total tumor mRNA vaccine. And then again, better than this is a non-specific vaccine. And then this is untreated or nanoparticle alone, empty vehicle, empty lipid particle. And so with that, for me, I've been in this lab for about 3 years with Dr. Sayer, who's my mentor. But for me individually, I've been doing, I've been on faculty just starting in August. And so these are the people who have directly funded my work, and Rein and Sarcoma I have to thank for allowing me to be a part of the mentorship program and allowing me to have a scholar also, and we'll hope to continue to collaborate and support some of the research that we're doing. I added this last slide because the last person talked about conference they have coming up. So I just wanted to advertise our conference. I'm the Adolescent Young Adult Cancer Director, and we have a AYA and Oncofertility Conference coming up here just in a couple weeks. And so virtual attendance is available. There's CME. If anyone's interested, we'd love to have you join us. That's all I have. Thank you.
Thanks. Thanks so much for a great talk. Questions for David?
Dr. Elliott, thanks so much. That's a great presentation. This is Chris Schultz, so I'm asking with an eye toward PPB, rhabdomyosarcomatous tumor in very young children. So I have 2 questions. One is related to the blood-brain barrier and your therapeutic approach, knowing that the CNS is a common cause of treatment failure for young children with PPP. And then as you design your clinical trial, I'm curious about your lower age limit of inclusion. Rhabdomyosarcomas are obviously a little more commonly seen in younger individuals, but PPP in particular is seen in very young individuals.
Yeah.
Kids are treating for relapse from 3 to 5 years of age. So wondering about ability to cross the blood-brain barrier or your thoughts on CNS disease from a primary extracranial sarcoma and then younger age limit for such one treatment.
Yeah, so our group, as I'm actually part of a neuro-oncology group. We have a large group. We have 5 PIs, and 3 of them are pediatric oncologists. I'm an adult oncologist, but I'm MedPeds trained, and so that's the AYA situation. Absolutely, the lower age limit would not be, it would be, 0 to probably 40 or 45. In terms of the blood-brain barrier, we have shown, one of our other trials is in high-grade glioma, and then also in glioblastoma. The first in human trial is a glioblastoma. Those are all open right now also. And so our drug, our vaccine is delivered intravenously, and we do see upregulation of peripheral blood cytokines, but also we do see change in the tumor microenvironment. And so we do suspect that we should have, even though that blood-brain barrier is there, we should see infiltration of healthy vaccinated immune cells within the brain space if we're extrapolating from the high-grade glioma data that we have, and also ependymoma and glioblastoma. So we also have medulloblastoma. So I do suspect that there should be vaccination of the CNS.
Hi, Dr. Elliott. Great talk. Speaking to your fusion negative work, beyond the difficulty in just isolating circulating tumor cells, what sort of criteria are you using for selecting mRNA targets for the protein?
What criteria are we using to select the mRNA, you said?
Yes.
So right now we used just tumor lysate for the mRNA, for the total tumor mRNA vaccine. We do have a pipeline that we're just finalizing and that we're going to use for neoantigen prioritization. And so, the neoantigen meaning that we can take the tumor and decide which mutations are most important to target. And so we do have that in the works, but right now we just use total tumor mRNA. Did I answer that question?
Yes, thank you.
Okay.
All right, well, thanks so much again, Dr. Elliott.
Thank you.
All right, so next we're thrilled to have Dr. Logan Spector, professor in the Suzanne Holmes Potter Chair in Pediatric Cancer Research at the University of Minnesota speak. He will discuss defining the GGAA-OM in Ewing sarcoma. So please join me in welcoming Dr. Spector. Good, thank you.
Thanks for having me, and thank you to Rein Sarcoma for all the support that I've gotten over the years. I should let you know that I have interests in all the bone sarcomas. Osteosarcoma was my original interest, and I'm afraid that over the years, Ewing sarcoma has become more my passion tumor. It's not that I don't also love to research osteosarcoma while hating the actual entity. But Ewing sarcoma is truly a fascinating disease that stands alone among cancers in many ways. And also that is what makes it amenable, I think, to completely describing the genetic risk. In other words, we could have in the space of a few years, and I'll describe how we'll get there, a complete map of the genetic risk for Ewing sarcoma. So I'll give you a little bit about epidemiology of Ewing sarcoma. I'll tell you about rare variant associations, the genome-wide association studies to date, which look at common variation. And then I'm going to tell you about the role of GGAA repeats in the genome and what I've come to term as the GGAA-ome. In other words, the characteristics of a human's complete collection of GGAA repeats. And then, oh, are my slides cut off? I'm sorry. And then I'll tell you the proposal that I'm making to the Children's Oncology Group to actually do what I said. So I call Ewing sarcoma the spotted zebra. All right. Those of you at RIS probably are familiar with the phrase, when you hear hoofbeats, think horses, not zebras. This is medical advice to medical students to think first of common diseases and not the rare things. But I call Ewing sarcoma the spotted zebra because even among rare cancers, it's extremely unusual for quite a few reasons. Number one, there is no animal cognate. I've only found in the literature one case report of a camel with a small round blue cell tumor, but they didn't actually do any molecular genetics to confirm that it was a EWS fly1. There was also a puppy with a small round blue cell tumor, but there's a conspicuous lack. As opposed to osteosarcoma, there have been dinosaur bones with, pathologically confirmed osteosarcoma. There's a highly mysterious cell of origin. We think that it's in the neural crest or mesenchymal lineages, but no definitive proof. There also is very little familiarity to Ewing sarcoma, and that's very unusual. Almost any other cancer, you can name a familial syndrome. And I think that the reason why this is starting to become clear, and I'll get to that in a minute. There's also very little evidence of environmental risk. I see that our postdoc, Dr. Cassie Clark, is on the line, and she just published a paper on air pollution and Ewing sarcoma risk. But she knows, and it was disclosed in the paper, they found an association with Latino ethnicity. I think that may be heavily confounded with genetics. There, in fact, is the widest difference in risk by ancestry of any cancer in Ewing sarcoma. There's a 9 to 10-fold difference in incidence between white children and Black children in the US, and this is replicated in international data that I'll show you in a second. There's also remarkable somatic genetic homogeneity of Ewing sarcoma, with up to 90% having EWS fly1, which while there are cooperating mutations that will make Ewing sarcoma more aggressive, EWS fly1 is thought to be sufficient for sarcomagenesis. And also when you cluster tumors by transcriptome, Ewing sarcoma is off in its own area. I should add that it's very highly polygenic, and I'll get to that. I actually ran out of room to list the other things that make it the spotted zebra. Another one is that there's a very exquisite cell type specificity to EWS fly1. It's considered toxic to most cell types, and there's only a few lineages where it will be tolerated. So that's part of this story. And then I got one other nugget of information that I hadn't known about, but there's something called the signatures of mutational processes, which you can think of as a fingerprint of all the exposures or processes that cells went through as they acquired mutations. Anyway, oddly, Ewing sarcoma, a share of them have a signature of UV damage, which is pretty weird because UV radiation only penetrates a few half a millimeter into the skin. Certainly does not reach the bone. So you got to wonder, what are these mysterious cells of origin doing? Are they moving up to the skin in order to get UV damage? I don't know. We'll find out. So if you want to learn about the extensive molecular biology that has been discerned or ascertained about Ewing sarcoma, I strongly suggest this review from Niccolò Righi in 2021. It's the scientists here will recognize this as the nice graphics from New England Journal of Medicine. But it basically talks about the importance of the EWS-FLI1 translocation, as well as a few other EWS fusions with other genes that act very similarly. But what you should pay attention to is the GGAA repeats. So these are what are called microsatellites. I've retermed it GGAAR just to make my grants a little more readable. And what these are 4-letter sequences of DNA that get stacked next to each other and form a repeat, all right? And the EWS-FLI1 fusion protein binds to these GGAA repeats in a length-dependent manner, all right? And there is like a sweet spot of length, but we don't know a lot about these repeats or their pattern in human populations, because the kind of sequencing that we've employed cannot resolve these very well. I can tell you the technical reasons for that, but the good news is there is now a way of discerning these with much more precision. Here's a paper from the king of EWS-FLI1 in the US, Steve Lesnick, who was here a couple of years ago. He has retired, and we now collaborate with the woman at the Nationwide who inherited all his reagents and data. And so this is just showing the molecular biologic experiments that confirm this length-dependent GGAA repeat binding. All right, so I already mentioned the difference in incidence by ancestry, and this is showing it to you in SEER data, which is like the US Cancer Registry. But more interestingly, several years ago, we looked at data from the International Agency for Research on Cancer, and we took that international incidence data and ranked it by the majority population or in each cancer registry. And to my surprise, the ancestry with the highest risk was Asian or just Pacific Islander or Maori, which is a further out branch of humanity. I don't think that ever would have come to light if we hadn't looked at these data. Why this is, I don't know. And it is based on small numbers, but it's pretty clear. So Pacific Islanders, followed by Middle Easterners, followed by Europeans, Latino or admixed Americans, South Asian. And then we get down here, and actually there's a cluster of East Asian. And in China, there were something like 30 million kids in the denominator and only a handful of cases. Quite confident that China can diagnose a small round blue cell tumor. This is an organic deficit in Ewing sarcoma or difference. And then at the very bottom, you see African countries, and there were no reported cases. I actually had to look up how to put an upper confidence limit on a 0 rate. So I think that this cannot be explained by exposure or environment. It can, however, be explained by differences, population differences in the GGAA-OM. So also, this came out a couple of months ago in Science. It's a colleague at Dana-Farber, Riaz Galani, who used short read data to look at what's called structural variation in the genome. It's not just the genome is not just the letters, but also how often these letters are replicated or deleted or inverted or stuck together. We call that structural variation. It turns out that there was a small degree of rare structural variation in DNA repair, which seems to be somewhat enriched in Ewing sarcoma. This combines with data looking at other types of rare variation. But here's the thing. Usually when you have a rare variant, it causes a big change in the function of a protein or a pathway, and it causes a very large difference in risk. All right, so kids with Li-Fraumeni syndrome have hundreds of times the risk of a particular tumor. This structural variation and other rare variation in Ewing sarcoma is really kind of weak sauce compared to other diseases. There's maybe a 5 to 7-fold difference in risk. That is very low for this kind of variation. And so it's a very odd situation where, and this may explain the lack of familiarity, the rare variation just isn't very strong in Ewing sarcoma. However, such rare variation as there is all seems to have to do with DNA repair. And so, you know, my suggestion is that the propensity to create the EWS-FLI1 translocation is perhaps spurred on by a little bit of defect in DNA repair. By the way, we cataloged this a couple of years ago, did a lit review of across childhood cancers looking for syndromic associations, and there was a notable dearth of them in Ewing sarcoma. So on the other hand, the GWAS, which only looks at common variation, has been incredibly productive. In fact, we calculate that you can get one new genome-wide locus for every 120 patients that you put into a GWAS. That's probably a world's record for a cancer. By contrast, they've genotyped something like 250,000 women with breast cancer, and they have 150 loci. So phase 3 is about to be published. I'm on it. There's 14 loci. The odds ratios are quite strong. The top one, and again, this is very odd for a common variant, has something like a 3-fold risk per allele, and they are very enriched for proximity to GGAA repeats. So we don't think these variants are actually doing anything. They're just tagging the variation that interacts with EWS-FLI1. And so I am now pursuing a complete description of what I call now the GGAAome in Ewing sarcoma. And so here's my model of how Ewing sarcoma happens. First, you have to get the EWS-FLI1 translocation, which happens more or less at random, but maybe with a little bit of help from a predisposition. And then you have to have it happen in a cell type that is permissive to EWS-FLI1. If it happens in some other cell type, that cell dies and you don't get Ewing sarcoma. If it happens to happen in the cell types that are amenable, then it's up to the character of your GGAAome, all right? The 3,000 or so GGA repeats in the genome, if they happen to be the right length to be receptive to EWS-FLI1, then the tumor may take off. If you are lucky to have a GGAAome that is unreceptive, then it's less likely to happen. So that's my model. So there are some critical questions that this brings up. Does the GGAAome underlie inter-individual differences in risk? Does it underlie ancestry-related differences? Is it related to metastasis at diagnosis and survival? And can we use this information to find critical downstream genes that are regulated by EWS FLY1 to be targets of therapy? And then there's some interesting questions that maybe NIH won't fund, but a postdoc will investigate, like, why do we even have a GGAome? They don't seem to have any function in normal cells. And are they subjected to genetic drift? And that's why we see this weird pattern across global populations. And then lastly, there's some suggestion that these kind of repeat expansions are the subject of de novo mutation, that is, difference between parent and child. And there is a slight suggestion of a parental age effect in Ewing sarcoma. So I also want to answer the question about whether these are appearing de novo. So I'm going to skip this, but our ability to look at these microsatellites, also called short tandem repeats, it has improved over time. And now with the advent of fairly economical long-read sequencing, we can look at this question. Short reads are great for single nucleotide variants, relatively cheap, low input, but they're bad for repetitive elements. And a lot of the other extras you get are hard to resolve. Long reads are the gold standard for structural variants and these kind of repeats. You also get methylation and what's called phasing, or the knowing which strand it's on, for free. The cons are it's still pretty expensive, especially compared to a $100 Ultima genome, and it requires pretty large input. And so it's kind of hard to find these samples. I'm not going to dwell on this one, but it just shows the improvement you get from long read sequencing. So my proposal is going to answer all these questions. We've going to start with Project Every Child in the Children's Oncology group, which has stored samples, and surprisingly, they're very multi-ethnic. So I think we're going to have the first look at non-European genomes. Get 250 European, 250 Latino, and then basically everyone else that COG has, and do an ancestry matched case control comparison of the GGAAome, comparing to healthy population in the All of Us study. And then also for those of you who follow along at NCI, they have been funding the Molecular Characterization Initiative through COG, which is upfront germline and tumor sequencing and RNA-seq. As of Monday, Ewing sarcoma is getting added. I expect there to be about 200 cases per year that are going to be providing sequencing data. It's available for free to the research public. And I plan to get a replication set here, and then also get parental DNA in order to answer the question of whether these are occurring de novo. And then separately, seeking to derive patient-derived induced pluripotent stem cells for the reason that we have a very interesting model where we can take these stem cells, differentiate them into neural crest cells, apply EWS FLY1, and we get a completely different transcriptome that resembles Ewing sarcoma. So we're able to directly study EWS FLY1's interaction with the genome. Anyway, this is just showing you that COG has quite a few diverse samples, which is going to underlie this study, and they have quite a bit of DNA, so I'm able to do long read. It's thinking about the last slide, but I'm pretty sure that it just says, thank you very much for listening, and I'm happy to take questions.
So questions for Dr. Snyder. Maybe I'll start with one. So I guess what I wasn't clear on whether ancestry difference in susceptibility is due to the frequency of these defects in DNA repair or the GGAM or both. So is that clear yet? No,
the Dana-Farber study was just using American data and it was mostly Europeans. So I don't know that anybody's gone and looked throughout the world, but actually there's good data that anything that's loss of function is going to have a similar prevalence no matter what ancestry, because those are so bad for, you know, evolutionarily that they basically appear and get snuffed out, you know, very quickly. However, the GGAA-ome, we do have some initial data suggesting that average GGAA repeat length differs by ancestry, and there is reference data coming out. These are enormous files, like 1 terabyte per whole genome for long read. So that's the difficulty. But my plan is to get this reference data and just say what I think is going to happen is we're going to find that, you know, Pacific Islanders, Middle Easterners, Europeans have GGAA repeats that are in the sweet spot. And then East Asian, African will have, you know, unamenable repeat lengths. Questions? Only other thing I'd say is, you know, NIH is the only agency that would ever fund this research. There isn't any, you know, money in this. And, you know, those of you who are giving money to Sarcoma Research, we appreciate it. But also in this moment, we could definitely use people telling your legislators that you support the NIH. And because otherwise, I don't know that I could ever pursue this research. Yeah. Thank you.
Thank you, Logan. All right, so our final presenter is also virtual. Dr. Scott Michael Schutze, a clinical professor of medical oncology at the University of Michigan. Dr. Schutze's presentation will focus on leiomyosarcoma and the LMS spore. So please join me in welcoming Dr. Schutze.
Hello, good afternoon or good morning. Are you able to hear me?
Yes, we can hear you.
Okay, should I share my slides?
Yes, go right ahead. We're all set. Got it. We can see.
Okay, let me see if I can get it into the presentation mode. How about now?
Yep, perfect.
All right, well, thanks very much for inviting me to come and present a little bit on our leiomyosarcoma spore. Spores are specialized programs of research excellence funded by the Translational Research Program of the National Cancer Institute. And I would also like to echo the last speaker that right now it's really important to let everyone know how important the NCI is to funding cancer research to help us generate new discoveries and to improve treatment for patients with cancer. Our spore is titled The Genetics and Genomics of Leiomyosarcoma, Improved Understanding of Cancer Biology and New Approaches to Diagnosis and Treatment. This spore was awarded in September of 2022, which is 30 years after the creation of the spore program by the National Cancer Institute. This is a 5-year award, and we're eligible for renewal in 2027. This particular spore is led by 2 investigators, myself, who's a clinical researcher at the University of Michigan, and Jonathan Fletcher, who's a basic translational researcher at Brigham and Women's Hospital in Boston. We assembled a number of really awesome investigators from 10 different institutions to work together, which is a little bit unique in the spore program. Most, not all, but most of the spores are single institution spores, so all of the work is done in one institution. But because of the nature of sarcoma and the nature of our focus here on leiomyosarcoma, we felt it was much more advantageous to bring together people not only around the country, but around the world to focus on this particular problem. So we have investigators not only from the United States, but Canada and Australia as well, all collaborating together. And I think very importantly, while the funding from the NCI is critical to doing a lot of the work that we do, it's not able to accomplish all of the work that we really need to do. And so many of these research programs require some augmentation or supplementation using funds from other areas. And in our case, we've been really fortunate to have support from philanthropy from not only Rein and Sarcoma, but National Leiomyosarcoma Foundation, the Sarcoma Foundation of America, the LMS 360 Fund, which is a philanthropic fund, and then more recently, the Susie Wolf Coughlin Leiomyosarcoma Research Fund. So the goals of our SPORE are to translate laboratory findings into the clinic to improve outcomes of sarcoma patients. And we're doing this through a number of areas. One is to improve our understanding of and exploitation of DNA damage repair vulnerabilities in leiomyosarcoma, to uncover the roles of germline DNA mutations, particularly in TP53, but also in other genes, including DNA repair genes, that lead to the development of leiomyosarcoma, to develop blood-based DNA biomarkers for leiomyosarcoma, to identify new avenues for sarcoma research, and to train the next generation of sarcoma researchers. So this is a map here showing all of the institutions that are participating in this LMS SPORE, with the most Western institution shown on the right here, the University of New South Wales in Australia. Within North America, we have the University of Utah participating, Mayo Clinic, as you can see, the University of Michigan, Brigham and Women's Hospital, Dana-Farber Cancer Institute, Nationwide Children's Hospital, and then in Canada, University of Toronto. This is a bit of a complicated slide, but it shows our overall organizational structure. The real focus in the SPORE is on translational projects, which are shown in the upper right part of the chart. We have 3 principal projects that we're focused on. Those projects are supported by the cores, which are shown below, the administrative core, biospecimen and biopathology core, and the data analysis core. Our programs shown over in the left lower part of the chart include the developmental research program and the career enhancement program that I'll talk a little bit more about. The SPORE is led by PIs, but we're supported by an executive committee. We're also supported by a recently formed internal advisory board, and then we have an external advisory board that helps to provide review of our progress and to provide suggestions and potentially help us to identify new areas of research. So the overall SPORE specific aims are really broken out into 3 principal projects. Project 1, and all of the projects are have to be led by a basic or translational researcher and a clinical researcher. And the idea behind the SPORE program was to bring together basic bench translational researchers and clinicians, clinical trialists, to try to really translate new developments into the clinic. So project 1 is led by the basic co-leader, Jonathan Fletcher, who's a pathologist and cytogeneticist at the Brigham and Women's Hospital, co-led by Suzanne George, who's a sarcoma medical oncologist at the Dana-Farber Cancer Institute. And the aims of this project are to characterize chromosomal instability in leiomyosarcoma, to evaluate TP53 mutations in DNA damage and the response to DNA damage in leiomyosarcoma samples, to characterize the response and resistance mechanisms to treatment with a inhibitor, a drug that inhibits a specific enzyme called DNA PK, which helps cells to repair or recover from DNA damage, and to evaluate synthetic lethality when inhibition of this enzyme is combined with different chemotherapies in leiomyosarcoma. And then to evaluate other genotoxic therapies for leiomyosarcoma that capitalize on this sort of inherent potential vulnerability in leiomyosarcoma, where there's a lot of DNA damage that takes place, and the sarcoma cell tries to respond to that DNA damage in a way to keep that cell viable, and trying to exploit ways of being able to sort of tip the edge to the side where the cells are not able to recover from the DNA damage and then go on to cell death. As part of this translational research, the projects are required to have a human endpoint, which can be a clinical trial or an observational study. And in this particular project, the clinical endpoint is a phase 1 trial combining low-dose doxorubicin, liposomal doxorubicin, with this inhibitor, oral inhibitor of DNA PK enzyme called peposertib in patients with leiomyosarcoma and other soft tissue sarcomas, with further expansion of this combination, specifically in patients with leiomyosarcoma. So the clinical trial is being funded and run through the Experimental Therapeutics Clinical Trials Network that's supported by the NCI. As I mentioned, this is a trial studying the combination of liposomal doxorubicin with this DNA PK inhibitor peposertib. It's led by Candace Haddix at Dana-Farber and Suzanne George, also at Dana-Farber, with the principal objectives of this phase 1 trial to determine the safety and tolerability of this combination, and then to determine sort of an optimal or recommended phase 2 dose of the combination for further study, assess how these drugs interact with each other related to metabolism of the drugs in the patient pharmacokinetics, and then to estimate the objective response rate and the progression-free survival rates in patients specifically with leiomyosarcoma being treated with this combination. In the dose escalation portion of this trial, patients with leiomyosarcoma, undifferentiated pleomorphic sarcoma, synovial sarcoma, dedifferentiated sarcoma, a few different kinds of sarcomas are able to participate in the dose expansion portion. Once that's completed, approximately 12 patients with leiomyosarcoma will participate in the dose expansion portion of the study. The study is currently enrolling at 4 different institutions shown below, but will expand to include some additional institutions. And right now, enrollment into the second dose level of the dose escalation portion of the study has been completed. And we're waiting for some safety readouts of the most recent patients that have been enrolled in order to expand to the next dose level. Project 2 really focuses on trying to understand the genetic basis of leiomyosarcoma development. This is led by the basic co-leader, David Thomas, at the University of New South Wales, with clinical co-leaders being Dr. Garber at Dana-Farber and Dr. Schiffman at the University of Utah. Within this program, there is also a population science-based study that's led by Dr. Ballinger, also at the University of New South Wales, and Wendy Coleman, a genetics counselor at the University of Utah. Aim 1 is to estimate the risk for cancers, different kinds of cancers, in families of patients with leiomyosarcoma, and also to evaluate the risk of second malignancies in patients diagnosed with leiomyosarcoma. Aim 2 is to examine germline pathogenic variants in patients with leiomyosarcoma to try to get an understanding of what kind of germline mutations might predispose patients to developing leiomyosarcoma. Aim 3 is to characterize leiomyosarcoma risk in patients who have a known pathogenic variant in TP53. This is a condition called Lee-Fraumeni. in which patients are at risk of getting a number of different kinds of cancers, including leiomyosarcoma, osteosarcoma, adrenal cortical cancer, breast cancer, leukemias, brain cancer, including a number of other types of cancers. And then the clinical endpoint with this project is to examine leiomyosarcoma patient understanding and attitudes towards germline genetic testing to try to get a little better handle on what do people know, what would they like to know, how would they like to receive that information, is it important to them to get tested, those sorts of questions. And with project 2, a lot of work in examining the familial aspects of leiomyosarcoma have been completed. This project really focused on trying to use the very rich databases that are available in the state of Utah. One is the Utah Population Database, which has very detailed genealogy records, which includes patients' medical records. And the second component is the Cancer Registry in Utah. And so using these databases, the team was able to identify 429 patients who were diagnosed with leiomyosarcoma in the state of Utah between 1995 and 2001, who also had information on first, second, third generation relatives. Within this 429 patients, 106 had the diagnosis of uterine leiomyosarcoma. So we're able to examine a little bit whether or not there are differences between the uterine and extrauterine leiomyosarcomas. In order to perform this research, they also identified over 2,000 control cases that were matched for age, sex, race, ethnicity, those sorts of things, among other characteristics, to perform a case control comparison. That work is sort of being finalized and is being sort of written up for publication. There are some interesting things that have been identified regarding other cancers that may be at increased incidence in families of patients who have leiomyosarcoma. What the research did clearly show is that leiomyosarcoma was more likely to be present in families in which they met criteria for having this leaf from any condition or an underlying pathogenic variant in the germline for P53. And then work is also underway to examine risk of cancers in the relatives. In AIM-2, this is evaluating really the underlying germline DNA abnormalities in patients with leiomyosarcoma to try to uncover what types of mutations might put people at risk of developing leiomyosarcoma that could potentially lead to better recommendations for screening in the future. And this work is being done using the International Sarcoma Kindred Study, which was primarily being driven out of Australia or managed by Australia, in which they've identified now over 300 patients with leiomyosarcoma who have undergone germline testing for genetic abnormalities, underlying gene abnormalities that could potentially be relevant to the development of leiomyosarcoma. We've initiated a collaboration with a project in the United States called Count Me in which patients can enroll through a web-based system and submit saliva or blood samples for genetic testing. And then we've also initiated a collaboration with Ambry Genetics, which does commercial germline DNA testing. And then briefly, the clinical endpoint in this particular project is evaluating patient attitudes about genetic testing. It's questionnaire-based, which can be done either online or through a paper questionnaire that's mailed to the patient. And we've expanded this work to not only include patients who are being enrolled in some of our SPORE studies, but also have expanded it to a number of individuals who are undergoing referral for genetic counseling and testing at Huntsman and other cancer center genetics clinics. And then project 3 is our project that's focused on trying to develop biomarkers for leiomyosarcoma. At present, there really aren't any good biomarkers for leiomyosarcoma that could help understand patient prognosis and also predict tumor response to different treatments. This Project is co-led by Dr. Crompton at Dana-Farber, Dr. Ciantis at the Mayo Clinic, and myself. This project has two aims. The first aim is to determine the association of circulating tumor DNA, the levels of the DNA, and also something called copy number alterations, which can be detected in the blood with patient outcome, so with their prognosis, and then also with prediction of response to chemotherapy. And aim two is to characterize and validate recurrent patterns of tumor heterogeneity and tumor evolution in patients on chemotherapy treatment. So trying to look and see how does that chemotherapy alter the underlying genetics and biology of the tumor, and how does that potentially lead to development of tumor resistance. And our clinical study is an observational study of biomarkers. We're looking at primarily at circulating tumor DNA in the blood, but we're also looking at radiomics, which is sort of ways to do high-level analysis of really a lot of fine characteristics that can be extracted from CT and MRI images. And this is being done in patients with metastatic leiomyosarcoma who are undergoing first-line chemotherapy. For this observational study, the primary objective is to examine the correlation of a change in the ctDNA in the blood with objective tumor response and progression-free survival on treatment. To examine the frequency of the ctDNA in patients with unresectable or metastatic LMS in relation to not only where the tumor started, but the burden of disease, which organs are affected, for example. And then to evaluate the radiomics or imaging characteristics in patients undergoing treatment to see if we can identify any patterns other than a change in size, which might predict which patients are benefiting from the chemotherapy treatment. This observational study is open at a number of different institutions around the United States, and we have two institutions in Australia who are also participating. It's for patients who have newly diagnosed metastatic leiomyosarcoma who are undergoing first-line therapy with either doxorubicin-based chemotherapy or gemcitabine and docetaxel, which is another regimen that's commonly used to treat this disease. We're collecting blood for circulating tumor DNA analysis. We're also looking at patients' germline DNA, and we're collecting tumor for analysis of the genetics of the leiomyosarcoma, and also looking at how the tumor responds to treatment. And then we're collecting CT and MRI images to do these additional analysis on imaging characteristics. And currently, 39 participants have enrolled in this observational study. We hope to have 150 enrolled by the end of 2025, and the total goal for enrollment is 200 participants. I'd like to just speak a little bit briefly about our programs. We have two programs. One is the Career Enhancement Program, and this is a program that provides award for early career investigators with the primary purpose to stimulate interests in young investigators into sarcoma and sarcoma research, and hopefully help to not only stimulate their interest, but to really cement their academic career in this area. We think that training the next generation of sarcoma researchers and investigators is very important. And so this is a mechanism to get young people interested in a career in sarcoma research. So to be eligible for the award, the applicant needs to have a faculty appointment. So they're usually an early assistant professor at a academic institution. They receive $50,000 in funds from the NCI federal grant, so federal funds, and then we match that with $50,000 from philanthropy. This is where one of the areas where philanthropy becomes very important for our project, our overall SPORE. And then if we feel that they've made adequate progress in their first year of funding, they're eligible for a second year of funding, which is entirely from philanthropic funds. In the first year of our SPORE, we provided a Career Enhancement Award to Dr. Nassif, who's at MD Anderson, and her project is looking to identify biomarker-based immune targets in different molecular subtypes of leiomyosarcoma, trying to understand if there are certain types of leiomyosarcoma that may be more amenable to targeting with immunotherapy-based treatments. In the second year, we awarded the Career Enhancement Award to Dr. Dermawan, who's a pathologist at the Cleveland Clinic. And she's looking at defining novel genomic risk stratification models and then trying to determine who, if there's sort of molecular patterns that could help to provide some prognosis for patients diagnosed with leiomyosarcoma, and also to take a deep dive into looking at different cellular lineages to see if she can identify different cells of origin that may give rise to different types of leiomyosarcoma. And in our third year, we were fortunate to have enough funds available to for 2 different awards, one from Candace Haddix, who's a oncologist, medical oncologist at Dana-Farber, who's characterizing biological mechanisms that determine whether leiomyosarcoma clinical course is very indolent or slow growing, which can happen, but is not the typical course, or if it's more typical, which tends to be more aggressive and rapidly progressive. And Dr. Resch, who's at the Johns Hopkins, is evaluating a combination of chemotherapy with a type of immune therapy to try to improve outcomes in osteosarcoma. And while our sport is focused on leiomyosarcoma, there are similarities between leiomyosarcoma, osteosarcoma, some other types of sarcomas like undifferentiated pleomorphic sarcoma. So some of the lessons learned in osteosarcoma could potentially be applicable to leiomyosarcoma. And then finally, in our developmental research program, this is really an area to try to identify new ideas for leiomyosarcoma related research. And again, $50,000 in federal funds is matched with $50,000 in philanthropic funds for the first year. And if adequate progress is made, then we renew for a second year with philanthropic funds. In our first year, Dr. Losa at Johns Hopkins was provided the award for evaluation of immunotherapy barriers in the leiomyosarcoma immune microenvironment. So trying to understand why leiomyosarcoma doesn't respond well to immunotherapy treatments, unlike some other types of cancers. Dr. Ciantes from the Mayo Clinic was awarded for her work in trying to do a deep dive into the underlying not only RNA expression, but protein expression in sarcomas to try to distinguish different subtypes and see if we could identify areas of new targets for therapy. Dr. Schaefer was also provided an award in year 2 and for her work in trying to understand how cell cycle dysregulation in sarcomas could be targeted with different types of therapies. This third year, we were able to award 2 awards, one to Dr. Kung for her work in, again, taking a look at the tumor immune microenvironment, but not only in the primary tissue, but comparing that to metastases to see if there are differences in how the immune system reacts to not only the primary sarcoma, but the metastases. And also provided an award to Dr. Nucci, a pathologist at the Brigham and Women's Hospital, to develop AI and deep learning system to improve the diagnosis of uterine leiomyosarcoma and to help really be able to select patients who may need or may not need chemotherapy treatment. So that's my overview of the sarcoma spore. I really would like to thank our patient advocates who helped provide input into our spore program. But more importantly, I'd like to thank all of the donors to sarcoma research, because sarcoma research is really underfunded by especially pharmaceutical companies, but also by the federal government in many instances. And so a lot of our work really depends on philanthropy to make the progress that we're making. So I think I'll end there. I need to stop sharing.
Thanks so much. Let's give Dr. Truce again. We now have time for about one question or so, if anybody has any.
I think I'm standing between you and your lunch. Is that right?
Yeah, I guess I would just ask, about the cell-free, or well, you talked about circulating tumor DNA. So are you looking at cell-free tumor DNA or also looking at DNA from leiomyosarcoma cells in circulation, if such cells are present, are you studying both?
So the technique that's being used is really looking at the total DNA, which would include cell DNA from cells that were essentially kind of broken apart at the time of collection, or that are circulating free outside of the context of the cell. So we're really taking plasma samples, and that's what's being analyzed. So we're not trying to select out intact leiomyosarcoma cells and quantitate them. That has been done in certain kinds of cancers. It's been done in mostly carcinomas, breast cancer, some other kinds of cancers. It's much more difficult to do in sarcomas, and so we're really focusing more on the cell-free DNA, not the circulating leiomyosarcoma cells in the bloodstream. And in our preliminary work, in about half of the patients, we're able to detect circulating DNA from leiomyosarcoma. It correlates a little bit with, but not completely, with the burden of disease. But it also seems to correlate more with kind of more aggressive disease. So patients that have more aggressive leiomyosarcoma tend to have higher levels of circulating tumor DNA than people that have less aggressive or more indolent disease.
Okay, great. Well, thank you. And thanks again for your presentation. All right, so I want to thank everybody again for joining us today. I just want to mention that you'll see on the agenda that there's one additional presentation that's been recorded from Dr. Michaela Sullivan from the Department of Orthopedic Surgery at Mayo Clinic and Dr. Matthew Hudek, also from Mayo Clinic. They're unable to present in person today, but they wanted to share their work with everybody. It focuses on a novel approach to sarcoma resection during surgery using intraoperative fluorescence angiography. And that presentation is available for viewing at a later time at your leisure if you'd like. And you can see the link provided on the agenda. So I thought today, we had an amazing set of presentations that covered everything from germline predisposition to early detection, interception, and treatment of sarcoma. And it's fascinating to think about how all those areas are moving forward. And it's also true that more ideas than ever before are being tried for sarcoma. And that's really the importance of research, funds for research to do this kind of work. If more ideas are tested, more of them will work. We stand a better chance of finding the things that work. So thank you to Rein and Sarcoma for focusing on these diseases. So there is lunch that will be served in the back, so feel free to help yourselves. This is an opportunity to network with colleagues and discuss the things that we heard today. After lunch, for those of you who are here, there's also an exciting optional lab tour. So at 1 o'clock, I will bring you over to my lab, as well as the lab of Robert Galvin. We both work on a form of sarcoma called malignant peripheral nerve sheath tumor. And we're happy to tell you about what we're doing. So, all right. Before we break, I also want to remind everybody that Rein and Sarcoma has some resources available on the table over here. So if you're in need of information, support, or just want to learn more about the mission, please pick up any materials that might be helpful for you to, they're free for you to take. Okay, so let's have lunch. And once again, thank you for being here.
Thanks.